Insights. And this time, I'm very delighted that we have the youngest Arthroscopy Society with us. And first of all, let me congratulate the Arthroscopy Society of NorthEast, which has just recently been formed. And they are our partners for the Arthroscopy Insights today. This society is on the states, including the Northeast, all the states. And today we have with us Dr. Bikash, Dr. Kashif, Dr. Thejaswi, and Dr. Mahibul, who are representing the Arthroscopy Society of NorthEast, and they will give us talks on arthroscopy portals, graft choice preparation, tunnel placement, its importance, and meniscus injuries. So I think this is going to be a great learning webinar, especially for the beginners. And I welcome all the delegates who have just joined us virtually on the OrthoTV portal. I also would like to introduce our experienced panelists for today. We have with us Dr. Chirag from Bangalore. Dr. Chirag is a very experienced arthroscopy surgeon and does great work around the knee as he does osteotomies as well. So Dr. Chirag recently conducted a very successful Bangalore arthroscopy course where more than 900 delegates attended this course. So Chirag, welcome and thank you for joining.
Thank you, sir.
We also have Dr. Sunny from Pune, who is my colleague at Sancheti Hospital. And Dr. Sunny also has great experience in knee arthroplasty as well as knee arthroscopy. And he does a lot of ACLs and meniscus repairs. So Dr. Sunny, we welcome you to today's Arthroscopy Insight.
Thank you, sir. Thank you, sir.
Without further ado, I would like to thank once again the ASNE. It's a very nice name, Arthroscopy Society of NorthEast, very catchy, for joining in today, and congratulations again. And let us kick off this Arthroscopy Insights webinar. The main aim is to understand the basics. Arthroscopy is all about seeing well. Arthroscopy is all about being able to visualize. And you can visualize only if you have your portals right. If you don't get the portals right, then it's going to be a problem to see, it's going to be a problem to operate, and your outcome is going to get affected. There are not just the two portals, but there are more portals which are the working portals and which are useful. And for this, to educate us more on the portals for arthroscopy of the knee, we have Dr. Kashif Ahmed, who will speak to us on the arthroscopy portals. So over to Dr. Kashif Ahmed. Who's the president of ASNE this time?
Yeah, president is Professor Ranjit Barua.
Okay.
Myself is the vice president.
Please congratulate him.
Bikash is the secretary. Dr. Bikash is the secretary. I am the vice president.
Bikash is the secretary. So when he talks, we'll introduce him. But in the end, if the president can join, I would request you to inform him. So let's go ahead with the talk from Dr. Kashif Ahmed on knee portals for arthroscopy. Over to you.
Yeah. So good evening, everyone. First of all, I would like to make sure, am I audible?
Yes, very well.
Yeah. So firstly, I would like to thank Dr. Parag sir for giving us the platform to present some few topics, few basic topics on arthroscopy of the knee joint. And I would also like to thank our ASNE group who has considered me to start the session, and also Dr. Ashok Sham for giving us the platform in OrthoTV and his entire team. So let's start with the first talk, that is the knee arthroscopy portals, some tips. Yeah, so when I was going through the old literature, so a very interesting technical note article was by S.J. Kim and his team from Seoul. And they had talked about the practical philosophy for positioning of portals in knee arthroscopy. And there's a very famous line which he starts the article with. This was a book, quite popular, classic book, Jonathan Livingston Seagull by Richard Bach. And he wrote, the gull sees farthest who flies the highest. So basically, for success in arthroscopy, it is critical to make the portals at a proper position, and the surgeon who makes the higher portals also obtains the wider panoramic view, like the gull. First, the location of portals should be flexible. It should suit the surgeon's need rather than a fixed location. And the second point is that the higher the portal in the knee arthroscopy, the wider the view inside the joint. So the key to success in arthroscopy, as Dr. Parag sir was saying, is that you need a very good portal. Apart from that, you need a good light source and the distension of the joint. So all of these are very important factors to clearly visualize the joint so that you can start doing what you need to do uh, in order to get the right results. So the prerequisites is obviously the position of the knee joint, understanding the anatomical landmarks. I've always have the skin marker, be it your thousandth case. It should always be there on the table, the marker pen and the blade to make the incision. So let us look at first the anatomical landmarks. So we start with the patella. So we find out the entire borders of the patella, the inferior, the medial, lateral, and the superior borders. We mark it with the pen. Then we go over to the next bony landmark, that is the tibial tuberosity. We mark it. And then we find out the medial and lateral borders of the patella tendon. At the same time, the tibial condyle, the plateau, that is both the medial side and the lateral side, and the femoral condyle, both medial and lateral side. And once we have marked these bony landmarks, we are understanding that we are concentrating on the knee joint, and then the exact the position which is marked here in red in this picture is the soft spot which we can all of us feel when we examine our own knees, both medially and laterally, and that's where our working areas are. Now, if you look at the portals, we have a wide variety, the anterolateral and the anteromedial portals, which is the classic two portals. Then we have the parapatellar, medial and lateral portals, the suprapatellar, medial and lateral portals. These are all the portals in the anterior aspect. And a very another very important portal is the central portal or the portal of Gilchrist. So the classic anterolateral portal, the first portal, is actually the viewing portal. It's the most versatile of all, and it's the palpable lateral soft spot which we consider as 1 centimeter just above the lateral joint line and adjacent to the lateral margin of the patellar tendon, and just 1 centimeter inferior to the inferior pole of the patella. So most of the structures are visualized, except we might struggle with the tibial insertion of the PCL and the undersurface of the anterior horn of the lateral meniscus. A superior placement will, restrict a little of the access, and obviously the access to the posterior medial structures is difficult. So too inferior placement of this portal will give the risk of injury to the anterior horn of the meniscus, and the infrapatellar fat pad will also come in our way. If we go slightly more medial, we have chances of damaging the patellar tendon. So ideal would be something in between, but at the same time, even if the people may have variations with the fat pad, and what I have learned from seniors is that most of them just try to remove as much what comes in the way and tries to retain as much that's possible. So the anteromedial portal, which is 1 centimeter above the medial joint line and just inferior to the patellar tip, it's the medial soft spot. We should always remember that this has to be done under arthroscopic visualization and skin illumination. So once we have done the anterolateral portal, we illuminate the opposite side, and it's always important to put in the needle so you can just have the trajectory. You know whether you're going to deal with the medial meniscus or you're dealing with an ACL reconstruction, whether your needle's trajectory is well visualized when you're doing the triangulation so that you can carry out your procedures easily. And this is the primary working portal, and it's also used alternately as a viewing portal. So, so the medial meniscus posterior horn, if we are trying to tackle, we have to make this medial portal a slightly lower side. We and it's always important that it's easier to carry out your ACL reconstruction when this medial portal, as I had shown earlier, uh, is as marked red here in the cross sign. The medial side is slightly away from the patellar tendon so that we have easy access for the medial surface of the lateral femoral condyle during the ACL. And then we have the superolateral portal, which is just lateral to the quadriceps tendon. And it's basically superior to the superolateral corner of the patella. And we look at the patellofemoral articulation through this, helps in all these plique excisions medially. And we can look at the patellar tracking. And then comes the other posterior portal, which is the posteromedial portal. This is the triangular soft spot, which is formed by the edge of the posteromedial femoral condyle and as well as the tibia. It's 1 centimeter above the joint line posteriorly. And it's always important that when you're making these posterior portals, that the landmarks are drawn before the distension of the knee joint. The knee is always in 90-degree flexion, and always make the portal after distending the joint. Then we have the accessory portals, which is the posterolateral portal, which is behind the lateral collateral ligament and anterior to the biceps tendon and the common peroneal nerve. The lateral meniscus posterior horn can be accessed through this. The synovectomies, if we have these loose bodies just going way behind, we can access them well through these accessory portals. Uh, just as if the audience we have young surgeons, I think what I was told by my seniors is you don't need to hesitate too much trying to make it so much minimally invasive. If you're struggling, you can always go more lateral and medial to the classic portals to make your life easier in the beginning. If you're struggling, say it's a very obese patient, or everyone's knees are little bit different when we're doing the cases. So we should not hesitate in making some portals that could help us in carrying forward our work. Then we have the proximal, mid-patellar, medial, and lateral portals, just around the edges of the patella, both medially and laterally. That also helps us in viewing the anterior compartment and the meniscocapsular structures. And another very important portal is the portal of Gilquist. I think many of us use it. It's the site which is just inferior to the pole of the patella in the midline through the patellar tendon. We need to be a little bit careful, need not mess around too much in that area to further injure the patellar tendon. But it's a very useful portal, and we should always do it when the tendon is taut in 90 degrees, and it helps us during the ACL reconstruction procedures. It helps us during arthroscopic avulsion fracture management, the meniscectomies, and we can also shift our instruments to use it as a primary viewing portal many a times during the ACL reconstructions. Then we have the accessory far medial and the far lateral portals, which goes further medial and lateral to the standard anteromedial and anterolateral portals. Again, always remember, you need to put the spinal needle first, under vision, use the illumination of the scope, the light source, and you should make sure that you always enter above the meniscus. So then coming to the incision, yes, many people go with the horizontal incision, some go with the vertical incision. It has both the advantage and disadvantage in terms of injury to the veins or the saphenous nerve branches. But what is important is that you need to cause no further harm, and so you need to be clearly visualizing the needle and then replacing it with the knife when you are doing the portal, when you're making the portal, so that the knife is completely under your control while you're getting that giving away sensation. So this one of these videos, which was from Arthrex, um, that I could find, and so this is on the classic and markings which I had shown earlier with all the medial, the bony landmarks and the patellar tendon. Um, so yeah, so the first obviously is the anterolateral portal. If you note carefully here, the anterolateral portal is a little bit closer to the patellar tendon, while the anteromedial portal is slightly more medial, so as to access for easy access of ACL reconstruction or the posterior horn of medial meniscus. And so here, as you can see, we make the horizontal incision first, have a good control over the knife blade, so that it doesn't just slip away, and you have to make sure that you are above the meniscus, you are in that soft spot. Always the trocar should be under your control with your index finger right over the trocar, so that you have control when you're just pushing in through and getting that give way feeling, and you're not just going and barging in and trying to fiddle with the cartilage. So so once we inflate the joint, and then we put in our scope, you start visualizing, you do the diagnostic, but at the same time, now to make the anteromedial portal, you have to, as usual, you have to see it under visualization. You have to see the spinal needle that's coming through. As you can see in the image here, you have to see it under visualization so that you know that you are actually going posteriorly. You can see the posterior horn there, medial meniscus. So we want to do some medial meniscus work. We need to have this in the right trajectory. And so the portal is made only once we are okay visualizing the needle. And once you take out the needle, you replace it with the knife. Again, good control over the knife with your fingers, and be stable while making the incision so that you don't want to injure anything inside. You will come to know once the joint fluid comes out that you have penetrated through the capsule. And it's also very important that you use the hemostat, the artery forceps, to further delineate the soft tissue so that your portal becomes wide enough. So the take-home message is that always plan your portals, surface marking in every case, no matter whichever case you're doing. Be flexible with the position of the portal. Do not hesitate as a beginner to under visualization to make the other portals so that you are more comfortable. Visualize with the needle before the incision. Be ready to swap the portals when needed. Say the ACL reconstruction to view the femoral tunnel. Be ready to revise the portals, and always go for a panoramic view like the seagull and not have a very narrow view. Thank you.
Thank you very much, Dr. Kashif. That was a great talk, and you dealt with the very basic thing of arthroscopy, these portals. You can stop sharing your screen. So now let us have some discussion on this. Uh, we are inviting questions, so I'll just check the chat box. But before that, I just wanted to ask Chirag, what are the indications? When do you like to make a posteromedial portal? Do you make it in every primary ACL reconstruction case or meniscus case? When do you make a posteromedial portal? And can you give us some tips and tricks on how to make a posteromedial portal during arthroscopy?
Thank you, sir. So this was a very wonderful insight by Dr. Kashif. Now, posterior medial portal becomes a very integral part, typically in your ACL injuries, because we know that some subset of these ACL injuries, at least 8 to 10% of them, do have ramp lesions. So in case I detect a ramp lesion, when I seep in my scope through my PCL and the medial femoral condyle and suspect a ramp lesion, I will definitely make a posterior medial portal after doing my needle test. That is very important. You always need to visualize your ramp well and repair your ramp well, because the inadequate visualization and inadequate access of your ramp repair will lead on to a failure of your ramp repair. So do not shy away from making your posterior medial portal. Second is sometimes we find a loose body in the posterior recess because of a cartilage flake. In case you suspect that, you find that on your primary arthroscopy, I would like to make a posteromedial portal to access my posteromedial side. Third is when I do my PCL reconstructions. These are my three primary indications.
Yes.
Of course, synovectomy becomes extended indication, but these are my primary three indications. Of course, as we talk about where do we place my portals, I always do it under vision. Knee in 90 degrees of knee flexion. I illuminate the posteromedial side, see my skin. Sometimes there are the superficial veins running along. And if you happen to puncture those veins, then you're ending up with some amount of bleed and all those things. That is better to be avoided. When I
Yes.
telescope from inside, I always see that synovial shelf which is there, and I will go either above or below, depending on what I'm going to do. In case I'm doing a ramp repair, I will do it below that. In case
Yes.
I'm using two portal on the posteromedial side, one is on top, one is on bottom.
Yes, great, great. Sunny, before the other panelists can also, the other speakers can also initiate discussion, but when would you like to do a posterolateral portal, and how difficult or easy it is to do a posterolateral portal? Posteromedial, as Dr. Chirag nicely explained to us, what are your indications for posterolateral portal, Sunny?
Yes, sir. So basically, posteromedial portal we make for two reasons: when you are doing the ramp as well as doing the PCL surgery. Posterolateral usually is required when you're doing a six portal technique for arthroscopic synovectomy.
Yes.
And usually, once you've done your posteromedial portal, it is difficult to visualize the posterolateral area. But when you have cleared your window, the septum, the posterior intermembranous septum between the ACL and PCL.
Yes.
From there, you can nicely visualize the posterolateral compartment. And
Yes.
as Chirag also highlighted, that you can see a illumination sign. And from there, you can make a posterolateral portal. Other way is using a Messenger rod. You can pass it from the posteromedial portal, pierce the septum, come to the lateral side. Be careful not to go posterior to the fibular head as well as the biphasefemoris insertion, because you're directly venturing the nerve over there. So that care has to be taken. So for arthroscopic synovectomies, for when you're dealing with
Yes.
infected septic knee arthritis, where we'll need a posterolateral portal.
Great. Yeah. So with the posterolateral portal, in my experience, I always make it indirectly what Dr. Sunny was saying, put a messenger rod, put it all the way across laterally, keep it a little higher above, and then wherever you can see that indenting on the skin, take a 11 blade and make a kind of an incision, and then get out the messenger rod and put your scope or your portal, the cannula through it. So that's the indication for posterolateral. Any quick one or two questions, because we have three more talks to go. Any of the speakers want to give any comments or questions, and then we'll go to the second talk by Dr. Bikash.
Just one last question to Dr.
Sure.
Chirag. Yeah. So basically, suppose we are trying to open up medially, we want to see the ramp lesion, and we try to struggle more, we do the pike resting, and we try to even open up more. Do you actually try to open up more, or straight away go ahead with the posteromedial portal?
See, posteromedial opening depends on where you're opening up. Assuming you're opening up in the joint lines, your opening may be about 8 millimeters. Now, if you're opening up, you are doing a pie crusting in a distal superficial MCL. and on your POL, you get a distension of about 1.1 centimeter. So I do it in two spots, just about 4 millimeters below the joint line, 4 to 5 millimeters below the joint line. That's in the posterior medial aspect. And then I also release it in the distal end of the superficial MCL. That gives me a distension of about 1.1 centimeter maximum. Do not go to overstretch more than that. This is the maximum distension what you can get. With this, your 4 millimeter scope can easily go inside, and you can even access your posterior compartment. Now it's very important to probe it. You know, your tunets grading, you can have staging, you can have the superficial superior surface tear, the inferior surface tear, or a complete ramp lesion. So it's, you need to identify which ramp lesion you're dealing with. If it is a complete ramp lesion, if it's a type 1, type 2 ramp lesion, I will do a all inside meniscus repair. These are type 3 lesions, which requires a accessory posterior portal for your repair.
Perfect. So thank you very much, Dr. Kashif. That was a great talk, good discussion. For the lack of time, there are a couple of more questions, but we have time in the end, we will take them. Let's go to the second talk, but before that, let me welcome Dr. Tejaswi, who has just joined us. Welcome, Dr. Tejaswi. We now go to
Good
the
evening,
second
sir.
talk.
Yeah, I wanted Professor Ranjit Barua has joined us.
Oh, yeah, I saw him, but now I don't see him. Dr. Ranjit, are you there?
Yeah,
I think he
he has
got
left, I think. Yeah.
signed off. Let
He was
him
there.
join again after your
Yeah,
talk.
sure.
Welcome him. He's the president, right?
Yeah, he is a president.
Yes, so we will welcome him after your talk. So now, after a basic talk on portals, which was very elegantly taken by Dr. Kashif, let's move on to the second talk on the graft choices. ACL reconstruction is one of the commonly done arthroscopic procedures in India, and for that, the graft choices has now become a little controversial with having the options of peroneus longus, quadriceps, and semiti, gracilis, bone tendon bone. So let us hear from Dr. Bikash. How do you decide what is the graft choice for your primary ACL reconstruction? Dr.
Uh,
Bikash, please.
yes, sir. Thank you, sir. So first of all, I'd like to thank OrthoTV and Parag sir for hosting us, the Arthroscopic Society of NorthEast, for this talk on basic arthroscopic procedures. My topic for today is graft choices and preparation for ACL reconstruction. So now, as we all know that there are graft options nowadays. The graft option we have are autografts, allografts, and synthetic grafts. Mostly in India, we are using autografts because allograft facility is not available in most of the locations. In autografts, the most common graft used are the patellar tendon bone graft, the hamstring graft, the bone quadriceps tendon graft, and quadriceps tendon graft. And Now, first, before moving to the grafts, should know what is the ideal graft property. So, what we ideally want from a graft is it should be biomechanically similar to the native ligament, should be easily harvestable, and after harvesting the graft, there should be very little graft site morbidity, and most importantly, it should have a good incorporation and a similar strength after incorporation. But ideal graft are difficult to find. Um, Yet, what options we have, we go with them. So, most commonly used are the autografts, which in India, most of us are using the autografts. The advantage of them are there's very low adverse inflammatory reactions after using an autograft. There's very less chance of disease transmission, and they go very good revasculation and recolonization, collagenization. So, the choice of the graft, we have the bone patellar tendon graft, the quadruple hamstring tendon graft, and the quadriceps tendon graft, which could be with the bone or a plain soft tissue quadriceps tendon graft. Now, the hamstring graft. This is the probably the most common graft used for ACL reconstruction. The reason being, it has a low donor site morbidity, and but a single strand is usually inadequate. The graft is usually tripled or quadrupled, and both the semitendinous and gracilis are used. Some use only semitendinous, and some also use a STG graft, the semitendinous gracilis graft. The quadruple strand are said to be native to the double bundle ACL. Now, the hamstring tendon graft, they are most widely used graft because of the advantages they have. That is a very small incision, and along with the incision only, we can most of the surgeon, they drill the tibial tunnel from that same incision. Also, there is no compromise in the extensor apparatus, no problem involving the patellar apex or tibial tuberosity as we see with bone patellar tendon bone graft. Then the skin incision is in a stable area. It is a favorable elastic modulus, and there's less risk of cyclops syndrome. Now, disadvantage is it is said to compromise some amount of internal rotation. Uh, s- there could be soft tissue hematoma at the side, and weakening of agonist. Now, it is said that in ACL, the agonists are the hamstrings. When we take the hamstring, the agonists are said to be weakened. That's why some surgeons, they doesn't prefer a hamstring graft. The graft preparation is laborious, and harvesting is also uh, it has some amount of learning curve, and there is chances of graft laxity which is more as when we compared it with bone patellar tendon bone graft. So now how do we harvest the graft? Make a 3 centimeter incision, 3 finger breadth distal to the joint line and 1 centimeter medial to the tibial crest. The sartorius fossa is identified and detected. The tendon are palpated, and a transverse incision is made inferior to the gracilis to separate both the tendon. Some surgeons, they make a L-shaped incision and evert the sartorius fossa altogether, and then they take out the tendon. Now both the tendons are separated from each other and tagged, and all adhesions are removed. This is very important because this semitendinosus is said to have a lot of uh, adhesions and branching. If these branches are not cut, then when we introduce a tendon stripper, it might go along one of the branches, and we might end up getting a very small graft. So now the tendon stripper is used. While harvesting the gracilis, the stripper is directed toward the pubic symphysis, and tendon stripper is advanced to the myotendinous junction. While harvesting the semity, the direction of the stripper is towards the ischial tuberosity. So this how the tendon stripper is introduced. Now after that, the graft preparation board is used to prepare the graft along with to tension it, and the residual before that, the residual muscle fibers are removed with a metallic ruler, and a running baseball type whip stitch suture of with a number 2 or number 5 non-absorbable suture is used, and the graft is prepared. Next graft is the bone patellar tendon bone graft. It is said to be the gold standard for ACL reconstruction by many authors. Here, what we do is we take the central strip of the bone, the patellar tendon, along with the bone from both tibial and the patellar aspect. The tibial of the tibial and the patellar bone, the length should be at least 25 mm, 20 to 25 mm, and the bone should be at least 10 mm width. So the blocks, both the patellar and tibial blocks are taken, and it is said to have a very high ultimate tensile load and very stiff graft. Mostly in mostly in our setting, we use the bone patellar tendon bone graft in case of revision ACL surgeries only. Now, this is the steps how we harvest it. We mark the patellar tendon in totality, and we mark the central 1/3 of the tendon, and the bone from both patellar side and the tibial side are uh, harvested using a mini saw. Now, disadvantages and complication of bone patellar tendon bone are the most common being the patellar tendon rupture. There are chances of patellar fractures, and in certain cases, in sometimes tibial fracture also. Quadriceps weakness and loss of full extension are the most important complications. There could be anterior knee pain, especially while kneeling, and there could be numbness due to injury to the infrapatellar branch of the saphenous nerve. Now, when we compare the hamstring versus bone patellar tendon bone graft, we see that the chances of laxity is more in hamstring, but and the kneeling pain is more in bone patellar tendon bone graft. But if we see the graft failure rate, range of motion, isokinetic strength, this is similar in both the group. Now coming to the next is the quadriceps tendon graft. It has attracted the interest recently. It is harvested usually with the patellar portion, but our very own Raji Raman sir has put a paper recently with in which the central tendon, central third of the this quadriceps tendon is used alone without the bone portion. Next, we come to the allografts, which are these are like very good, but the thing is most important concern is about their availability. The most common graft used here are the bone patellar tendon bone, then the hamstrings, the tendo-Achilles or tibialis posterior anterior graft. Advantages of allograft is we don't have to worry about the harvest site morbidity. We can take the predictable amount of graft size. There's shorter operating time because we harvest them beforehand, and it's easier in post-recovery period. Now, disadvantage is there's risk of disease transmission, possible immunogenicity, slower incorporation. A sterilization is recommended for this graft, and irradiated allograft are likely to fail. So before going for an allograft, we have to do the screening of the donor by for any autoimmune disease, rheumatoid arthritis, SLE, and the donor should be tested for transmissible disease, especially the blood transmissible disease like hepatitis B, HIV, SCV, and human T cell lymphotrophic viruses and syphilis. The graft should be harvested within 24 hours of the dead body, and within 15 hours if the body is not cooled, and should be harvested in an aseptic technique. Now, allograft and autograft both go through 4 stages of transplantation. In the first stage, there is necrosis, then revascularization, then cellular proliferation, and remodeling. This the whole process is known as collagenation, and it takes around 6 weeks to 3 months. Neither of them usually said to return to the original strength. Another graph which are very not very used very commonly in our Indian setup is synthetic ligaments. There are ligaments like Tevira, Gore-Tex, and Stryker ligaments. They are prosthetic ligaments, and as an stent augmenting an autogenous graft, and as a scaffold stimulate collagen tissue ingrowth. But they have poor biocompatibility, high rupture rate, and high chances of synovitis, plus high cost and need for a lateral incision. So the take-home message is ideal graft is yet to be available. Bone patellar tendon bone graft said to be gold standard. Hamstring has a minimal donor site morbidity, and hamstring graft has problem with tendon junction healing. Allograft has poor result in terms of re-rupture rates and immunity. Allograft is used in multi-ligamentous injury or in revision, and synthetic graft are still in evolution. Thank you.
Thank you, Dr. Bikash. That was a nice basic talk. Let's open it up for a few questions. You can stop sharing your screen. So, Sunny, can I just ask you, what are the various graft options which are available to you in two scenarios? One is if you're doing a primary ACL, and second is if you're doing a revision or a multi-ligament. So what are the various autografts which you can harvest from the body?
Yeah, so when you're doing a primary ACL reconstruction, you have the hamstring, the semigracilis from the same leg. We can take the peroneus graft as well for primary situations. The that is what which are commonly used. When we go on to have a revision ACL, we usually tend to, if you are going to go for a revision with a hamstring graft, then we use the contralateral leg semigracilis, or we can take peroneus if you're doing a multi-ligament reconstruction, and central quadriceps tendon isolatedly or with a bone plug, the patellar bone plug. BTB graft is definitely a graft choice in young athletes and sports individuals. So usually these are the graft options when you're considering autografts in a primary and a revision scenario.
Yeah. So regarding BTB and SEMI-T, there is so much of confusion on which is a better graft and which is not. But if you see the literature, people started with BTB, they moved on to SEMI-T, and now again people are moving back to BTB. If you see biomechanically, it's definitely a stronger graft. And many people say that if the patient is an elite athlete or if the patient is a rugby player or a football player, I would like to do a BTB. But then why not do it for everybody? Everybody gets the advantage. So I think this is more of how you're trained, what you are better in doing. But end of the day, there are certain indications which are there for SEMI-T, there are certain indications for BTB, and of course, certain indications for the other type of grafts. With this, let me ask Chirag, lot of things are now coming in about the synthetic grafts. People are talking about the Jewel ACL. Dr. Bikash also showed us the other synthetic grafts. Long time ago, there was a time about, I remember 2 decades ago when there were the synthetic grafts. The Chinese used to use it a lot, but then it went out of fashion, out of vogue because they were having bad results. But now again, they are coming back. So your thoughts on the synthetic ligaments, and especially the Jewel ACL, Chirag?
Yes, sir. So the synthetic grafts have seen two curves. The first generation grafts were a failure because of various reasons. One is the most common reason used to be the synovitis reaction what they had. Second is the strength of the graft where was not great, and third there was no tissue incorporation because they were highly closely knitted graft. So this has been the few things have been eliminated in the recent graphs, synthetic graphs. What we have, the jewel graph, what you're talking about, is the polyester graph. What we have, they are loosely woven in the sense they are highly porous, which allows tissue incorporation and infiltration into that. Of course, the long-term literature is yet to be coming in. We have mid-term data, which appears to be very challenging and promising. The only thing what is there is the native, the uh, the flexibility or the elasticity of these graphs are not as similar to that of the native ACL. Other than that, load to failure is much more than a native ACL, where we look at a six-fold hamstring graft or a four-fold hamstring graft, which is about 4,200 Newton load to failure. The synthetic grafts are much higher, about 5,200 Newton force. So it is definitely much more stiffer, much more robust graft, but certain things are still not answered.
Yes,
But of
yes.
course, there are specific indications. In my practice, I do use it probably for single bundle augmentations in hyper obese patients, in hyper lax patients. These are my current indications,
Right.
not in isolation. Yes, sir.
Okay, any quick questions or comments? We have two more talks to go and we'll move to the third talk. But any comments from the speakers from the ASNI Society or yes, any thoughts on or any comments, questions? Okay, if not,
Sir, I
then
want
let
to ask
us.
one question.
Sure,
Dr.
Dr.
Parag,
Sani.
your thoughts
Yeah.
on peroneus graft, which is
So that's a great question. Because, I'm glad you asked it, Dr. Sani, because that's also on the chat box. But Peroneus longus is a graft which has now become very popular. This graft is more reserved for the revision scenario. The primary ACL reconstruction, people are taking the SEMI-T or the BTB, whatever they are used to. But Peroneus longus is a great graft. It is being a little bit challenged that it causes foot deformities post-op 3 or 4 months later. But we have been using it for a long time. And I feel peroneus longus really does not affect the foot function. And I am becoming a big fan of peroneus longus because it's very easy to harvest. We get a long graft, and you can get easily sometimes, threefold or fourfold up to 11 or 12 at times. So it's a very robust graft. And I think people should use it more and not worry about the foot dysfunction. People say it can cause some deformities, can have delayed pain. But except the foot surgeons, I think nobody believes in that. And as an arthroscopy surgeon, I'm very confident that it does not really impact the foot function. And I have no hesitation to use peroneus longus when required.
Thank you, sir.
Okay, so thank you very much. Let's go to the third talk. And we have talked about portals, we've talked about graft options. The next thing to get a good ACL reconstruction is to get the portals right, the tunnels right. So I think to get a good tunnel placement, it is important that we have good vision. And once we have the good vision, we have the proper jigs. We place them at the right anatomic points, because the entry and exit is dictated by the jig. So I think it is more important to understand how to place the jig, how to identify the anatomical point. And for this, we have Dr. Thejaswani to tell us about the importance of tunnel placement. Okay, over to Dr. Thejaswi. Thank you for joining us, and please tell us.
Good evening, sir. Am I audible? Am I audible?
Very well.
Yeah. Good evening, sir. First of all, thank you, everyone. Thank you, Sancheti, sir. Thank you, Dr. Sunny and Dr. Chirag for joining. Thank you for Dr. Ashok to organize this. I would like to share my screen.
Sure.
So I think we have already done with, as sir told, that we have done with portal, we have done with grafts, and then now is the time to place. Hello.
Yeah, please continue. Sorry.
Yeah, I'm not able to share my screen actually.
There'll be a function down there.
Yeah.
Are you a co-host? Yes.
No needed.
Not required.
Just that the green.
You can do Alt S.
Just press the green button once.
Yeah. But it's
Alt
I
S.
think my laptop froze.
So maybe what we can do is just try once. Otherwise, we can go to the fourth talk by Dr. Mahibul and come back to you. Just try one more time.
Yes, sir.
What is happening on your screen?
No, it's frozen.
Okay, so just we'll come back to you.
You can.
Yes, sir. I think we can continue with my
Just log out and
You can log out and rejoin again.
we will
I'll-
go to the next important topic. Whenever you're doing ACLs, we always have concomitant MCL meniscus injuries, and it is very important to deal with these meniscal injuries appropriately. Meniscus saving the meniscus is a big thing now, and whenever possible, we have to repair all the tears of the meniscus. So let us hear from Dr. Mahibul on meniscal injuries, meniscal tears, and what is their management. Thanks, Dr. Mahibul, for joining, and over to you.
Thank you, Parag, sir.
I don't know.
Yeah, am I audible?
Yes.
Yeah, pretty well.
Second floor.
Yeah, we can see your screen as well.
Yes. Yeah, is it okay? Everything is.
Yes, perfect.
Yeah,
Beautiful.
Thank you, Parag, sir. I want to thank Parag, sir, and OrthoTV for giving me this opportunity. Today, I will be discussing the current treatment practices for meniscus injury. An area of growing importance is sports and arthroscopic preserve surgery. With evolving technique and increasing emphasis on meniscal preservation is crucial. We stay updated on the latest evidences, indications, and surgical advancement to improve the patient outcome. Meniscal injury occurs in about 61 cases per lakh population. Acute trauma-related tears are common among active young and athletes, while degenerative tears affect the elderly. ACL injury significantly increases the risk of meniscal tear, with incidence ranging from 22 to 86%, highlighting the importance of early diagnosis and management. The meniscus functions as a joint filler, bridging the incongruity between the femoral and the tibial surfaces to ensure smooth joint stability. It also plays a protective role by preventing capsular and synovial impingement during flexion and extension, thereby facilitating smooth knee function and reducing the risk of mechanical irritation or injury. The meniscus covers approximately half to two-thirds of the tibial articular surface and plays a crucial role in load bearing. They transmit about 40 to 70% of the joint load. The medial meniscus bears about 50% of the load, while the lateral meniscus handles up to about 70% of the load, thus aiding joint stability and longevity. Meniscectomy significantly alters the joint biomechanics. Removing the middle meniscus increases the contact stress by around 100%, raising the risk of early osteoarthritis. The lateral meniscectomy causes even greater stress elevation, up to 200 to 300%, due to lateral meniscus, as the lateral meniscus bears the higher load, making preservation crucial to manage joint function and longevity. Meniscus tear presence in various patterns is affecting treatment decision. Vertical, longitudinal, peripheral, and buccal tears often occurs in vascular zone and are very repairable, while the radial flap tears and horizontal cleavages tear disrupt the meniscal integrity. Complex degenerative tears, common in older patients, typically require debridement over repair due to poor healing potential. The ideal scenario for meniscus repair includes an acute 1 to 2 centimeter long tear located peripherally in a young individual, especially when associated with anterior cruciate ligament reconstruction. These factors promote optimal healing due to good vascularity, biological support from ACL surgery, and favorable tissue quality in young patients. This table summarizes the meniscal tear repairability based on its zone, tear type, chronicity, and size. Longitudinal tears in the red zone and red-white zone, especially if it is acute, and if the size is around 1.5 to 4 centimeter, have the best repair potential. Radial tears, flap tears, and those in the white-white zone, particularly if chronic or damaged, have reduced repairability. Now coming to the vascular supply, the meniscus receives blood supply primarily from the genicular arteries, forming a perimeniscal capillary plexus. The outer red zone is well vascularized, enabling healing, while the red-white zone has limited supply, while the inner red zone is avascular, and it relies on the synovial diffusion, making tears in this region very likely to heal. Now coming to the non-surgical treatment modalities, it includes RICE, that is rest, ice, compression, and elevation, along with NSAID for pain management. Physical therapy focuses on strengthening the surrounding muscles and restoring range of motion. It is typically considered for stable, small, or degenerative tears, especially in older or low-demanding patients. Meniscectomy is indicated for irreparable tears such as radial, flap, horizontal, and complex patterns, especially in the white-white zone, where healing potential is very poor due to lack of blood supply. When repair is not feasible, partial meniscectomy helps relieve symptoms and restore knee function by removing the unstable torn fragment. The primary goal of meniscectomy is to debride the torn portion while preserving a stable meniscus rim. Meniscal preservation is preferred to maintain joint function. Around 80% of patients report satisfactory outcome at 5 years. However, lateral meniscectomy often leads to accelerated joint degeneration, highlighting the importance of conservative resection. Now, this table outlines the indication for meniscus repair. Ideal condition should have a vertical tear of 1 to 4 centimeter located in the red vascular zone, and in younger patients less than 40 years and have no mechanical axis malalignment. Repair are more successful when the tear is acute, that is less than 6 weeks, or occurs with ACL reconstruction. Relative contraindication for meniscal repair include advanced osteoarthritis, complex tear pattern, and poor meniscal tissue quality, which reduce healing potential. ACL deficiency can impair joint stability, compromise repair success. Additionally, a non-compliant patient or high-risk lifestyle may hinder the post-operative healing, making conservative or alternative treatment approaches more appropriate in such cases. Now coming to different repair methods, open repair is not done nowadays. It has been shown in many reports that arthroscopic repair reduces the surgical morbidity. So what are different techniques? The first one is the inside-out repair. In this procedure, sutures are passed from inside the joint to outside through small incisions, and then the suture is tied over the capsule. It provides excellent healing rate, especially for longitudinal peripheral tears, but requires careful handling to avoid neurovascular injuries. These are the different needles that are used for inside-out repair, and these are trays that are used. Now coming to the next technique is the outside-in technique. Outside-in meniscus repair is ideal for anterior horn and middle body retrievers. Needles are passed from outside the joint through the meniscus, and sutures are tied externally. This technique often requires precise control, minimal invasiveness, and reduce potential risk of posterior structure injury, making it especially useful for smaller or anterior peripheral tears. Now, outside-in meniscal repair allows precise vertical suture placement with excellent visualization. It offers easy access to the anterior meniscus and minimizes the risk of articular cartilage damage. This technique avoids injury to the saphenous nerve and vein, and is particularly used for securing meniscal replacement effectively. Outside-in meniscus repair has a limitation, include difficulty in placing the peripheral sutures in the far posterior horn. The mulberry knot that we tie abrade the articular surface before they are absorbed. Additionally, needle placement requires experience and precision, making the technique more challenging for less experienced surgeons like us. The all-inside technique is the easiest, actually, and the most advanced technique to assess and fix the posterior horn tears without external incision. It requires surgical time, it reduces the surgical time and minimizes complication associated with inside-out or outside-in technique. The fourth generation device enables secure suture placement directly within the joint, improving efficiency and reducing neurovascular complication. All-inside meniscus repair uses self-adjusting device with anchors placed behind the capsule and sliding knots that allow controlled tightening by the surgeon. Mechanical studies has shown that repair is often comparable to outside-in techniques, making them reliable for secure fixation, especially in the posterior horn. Now, meniscus repair has shown a success rate of 70 to 95% across various techniques, reflecting favorable clinical outcome. However, second loop arthroscopy often reveals low healing rate, ranging from 45 to 91%. The presence of ligament laxity reduces success, with reported rate dropping to about 30 to 70% due to instability affecting healing. Conversely, when meniscus repair is performed along with ACL reconstruction, success rate improve and it reaches about 90%. This improved outcome is attributed to enhanced joint stability and favorable biological environment created by concurrent ACL reconstruction. Overall outcome depends on tear type, stability, surgical technique, and associated interarticular pathology. The complications of meniscus repair includes neurovascular injury, especially to the saphenous or peroneal nerve, infection, joint stiffness, and re-tear or failure of healing. Other risks involve synovitis, chondral damage from implant or suture, and implant migration or breakage in all inside devices. Proper technique reduces this risk significantly. Now coming to the after treatment of meniscus repair depends on the tear size, extent, and stability. Small stable tear we may allow early mobilization, while larger tears or unstable tears require restricted weight bearing. Rehabilitation is more conservative if repair is combined with ligament reconstruction, which ensures optimal healing and joint stability during the recovery period. Postoperative care following meniscus repair involves using of knee immobilizer for 7 to 10 days to protect the repair. Range of motion exercises limited to 20 to 80 degrees should be performed 4 times daily for about 20 minutes to maintain mobility. 2 touchdown weight bearing is allowed after 2 to 4 weeks, progressive, and it progress to full weight bearing by 4 to 6 weeks. Jogging can typically be allowed around 3 weeks post-surgery, and return to sports is usually done after 6 months, depending on the healing, which this also depends on the healing and functional recovery. Adherence to this rehabilitation protocol is essential to optimize the healing and ensuring that the long-term success of the repair. Now coming to the tips and tricks, successful meniscus repair require proper technique and positioning. For posterior repair, the knee should be kept at 10 to 20 degree flexion. For intramedullary repair, flexion should be around 40 to 50 degree. And for lateral side repair, maintain at 90 degree flexion to optimize the access. Thorough preparation of the meniscus and parameniscal tissue using a rest promotes healing. We use 5 to 6 mm working cannulas on the ipsilateral side to avoid suture management and reduce soft tissue trauma. Sutures should be placed 3 to 4 millimeter apart and to ensure secure fixation and uniform load transmission. Meticulous technique and precision enhance healing rate and clinical outcome. Now, the take-home message: meniscal repair plays a vital role in preserving knee function and delaying osteoarthritis. The key to successful outcome lies in the accurately identifying repairable tears. Factors such as patient age, tear location and type, cause of injury, associated ligamentous injury, and overall patient profile significantly influences healing. Each of these should be carefully considered and when planning the treatment protocol. Whenever possible, all repairable meniscus tears should be addressed to preserve meniscus function and joint integrity. Proper surgical technique, appropriate rehabilitation, and patient selection are essential to maximize healing and long-term results. Meniscus preservation should maintain a priority in knee injuries. Thank you.
Thank you very much, Dr. Mahibul. That was a nice talk on the basic aspects of meniscal injuries, meniscal repair. So you can stop sharing your screen and we'll just take a couple of questions. Dr. Chirag, what
Yes,
are
sir.
your indications that you will not attempt a repair? You know, we've always had the dictum that save the meniscus, the red, of course we have to suture, but red and white also we are attempting to repair. But which are the
Yes.
cases that you would now think I have to do a meniscectomy or partial meniscus resection?
The primary indication of a partial meniscectomy is a degenerative tear. If it's a degenerative tear, I will not repair it. If the
Yes.
collagen stage is more than stage 2, when I scope the knee, then the meniscus repair become obsolete. Flap tears used to be an indication for resection, but if the flap tear is big now, we balance it and repair it.
Yes.
That could be an relative indication for meniscectomy. And irreparable meniscus tears, if you have a double tear, I would resect out the inner third and then repair the second zone of double tear repair. So these are the current indications where I may do a partial meniscectomy. But barring that, unless I retain 3 to 4 millimeters of the peripheral rim, I'm still okay doing a partial meniscectomy.
So there's one question which has come on the chat box. The question is from Dr. Jitu. He's asking that in an obese patient, primary ACL was done using the hamstring graft. Within 4 to 5 weeks, the patient had an injury again and tore the ACL graft. So the patient now has again a tear of the reconstructed ACL. So Dr. Sunny, how would you approach this patient who has a re-tear, obese patient, BMI more than 32, with a re-tear of her hamstring graft? So what will be your management protocol for this person?
Yeah, so first of all, having a graft tear within 4 to 5 weeks of a primary ACL itself shows that the patient is non-compliant, or he would have inadvertently done something which he should not have done, either any sports activity, or it may be mistakenly an accidental slip and fall also. So I would like to go more into the details of the history. So obese patient, more than 35 BMI, having a graft failure 5 weeks back. I'll be skeptical to redo it again. So I'll reanalyze him, find out his factors, the cortical function. I'll rehab him too for a while, at least for next 2-3 months, understand his symptoms, recheck for his instability symptoms. And if he really comes with a symptomatic instability for more like 3 months down the line, then I would go in and do a revision ACL for him. with a proper
Okay.
understanding, do his scanogram and identify the bony anatomy as well.
So Chirag, the patient is posted for a revision ACL. Dr. Jitu also wants to know what will be the graft choice now for a revision ACL, especially considering the high BMI.
Yes, sir. So the graft is failed at 4 to 5 weeks. That means either it's a fixation failure or the graft failure. Of course,
Yes.
we need to also think of traumatic failure, but patient usually 4 to 5 weeks, they do not have a repeat trauma. They're braced usually. So my graft choice will definitely not be a contralateral hamstring. So I will definitely think of a thicker and steadier graft. Since the tunnels are already there, I need to have a graft which has got much more diameter than the primary ACL reconstruction. So the graft choice here would either be a BTB or a quadriceps tendon graft for me.
Quadriceps tendon. What about
Right.
peroneus longus?
Sir, since it's a revision and bone tunnel already being there, I would rather rely on a bone to bone healing. So my
Okay.
primary graft choice for revisions are BTB. In case the patient is petite, not having adequate length of
Patella tendon.
patella tendon, then I may think about a peroneus tendon graft.
Okay. So fine. So any questions or any comments from the speakers, Dr.
I had
Bikash?
a question,
Kashif?
Dr. Sirag.
Yes.
Yes.
Recently, I had a patient. There was a bucket handle tear in a discoid meniscus. So how to
Yeah.
approach these cases?
So we need to understand that the pattern of three types of discoid meniscus. Hello?
Yeah.
Am I
Yes.
audible? Yeah.
Yeah, yeah.
Yes.
Yeah. One is incomplete, complete, and the Risberg type. In the third type, there's no capsulo meniscal attachment. These are usually free meniscus lying down inside. So you can mistake that as a bucket handle meniscus. You need to identify, is it an intrasubstance bucket handle or inherently it is bucketed. So in case of type 3, of course you resect it out. In case it's a complete discoid meniscus, I would probably resect out the bucketed tear and retain the peripheral half a centimeter of the meniscus. Usually we find a horizontal cleavage kind of a tear
Yes.
along with the bucket handle tear. So I would resect out the bucket handle fragment and repair the horizontal tear component of it.
Thank you.
Okay, okay. And sometimes what will happen, a bucket handle tear itself will kind of be therapeutic because if it is torn in a proper way, it will help in the refashioning of the discoid also, which we usually do. So what Chirag said is right, that you have to classify what type it is and then decide the further management. So while we are waiting for Dr. Thejaswi to rejoin, I think he's having some computer issues. Any more questions on any of the three topics? There's one more question which has come from the chat box. The question is by Dr. Farad. He is asking that if whenever you take grafts, let's say a BTB or a hamstring graft, especially a soft tissue graft, is there any role of kind of putting PRP at the ends of graft where they go into the tunnel? So that's a very specific and a pertinent question. Role of PRP at the ends of the grafts while passing in the grafts into the tunnels. So Chirag, do you see any role of PRP at all?
Not in my practice though. Sir, there have been some papers regarding this, but I feel that the healing is always in the mouth in a soft tissue graft. So putting it into the tunnel, I don't know how relevant it is. And there's always a screw and bone interface between the graft. So the role of it is debatable.
Yes.
We rely on the sharpest fibers in the mouth of the graft in the soft tissue graft
Yes.
healing. For me,
Yeah,
there's no role.
completely. So, to answer your question, Dr. Farad, I think there is no role to use PRP, especially for a graft at the ends of the graft. PRP has been shown to have some useful effects in meniscal repairs when you
Yes.
want to augment the repair. So you can inject the PRP into the tear or around the meniscosynovial junction. But for a graft, I would not hesitate to say that it has no role. And even though some articles are there, it is not the standard of practice. So before we go to the last talk, we have Dr. Ranjit, who is the president of the Northeast Arthroscopy Society, ASNE. I would request Dr. Ranjit to put on his camera and unmute so he can say a few words before we go to the last talk. Can somebody call Dr. Thejaswi so we know whether he's joining or not? Otherwise, we can take some more questions. Dr. Ranjit, can you hear us?
So meanwhile, I would like to
Yes,
ask a
please.
question
Sure.
to Chirag as well as you. So what is your take of antibiotic soaking of the graft before you do your ACL? As well as one thing, if by inadvertently the graft falls down or it becomes unsterile, what are your treatment strategies? Would you discard the graft and go in for a new graft, or you treat that graft and use it in your cases?
Yeah, excellent question, Sunny. So two questions here. The role of wrapping the graft with antibiotic solution. The answer to the first question is definitely yes. Vancomycin wrapped grafts are becoming very popular, and it has definitely shown to reduce the risk of infections. And now it has become a standard of practice to use the vancomycin wrapped grafts. So, Chirag, do you agree, or do you have any thoughts on this?
For me, it's a routine practice, sir. I do not shy away from soaking my graft.
Yes,
Gauze is always wrapped around
yes,
it.
perfect.
Uh, we have seen that the tenocytes do take in the vancomycin
Yeah. The
wraps.
second question before we ask Dr. Ranjit to speak, Chirag, if the graft falls, your sister is a new sister and she's not passing the graft properly, you're in a bad mood, and you drop the graft down on the floor. What do, Chirag? Don't
Sir, I
fire
think
the sister first, huh?
so. I think this is one complication we should not have.
Okay,
uh,
yeah,
because it is unjust on the patient's part of it, that we drop a graft. So we have to be very, very meticulous in preparing and keeping our graft aside. To all the youngsters watching here, make sure that we have a bowl which is kept separately. Once a graft is prepared, it is to be kept inside. In my practice, even till today, the graft, I take it from the table to the from the graph preparation table to my operating table myself. So that has to be handled by the surgeon himself. I still do not rely on any one of my assistants for transporting that graft.
yeah,
We need to be
surely.
as
Prevention
professional.
is better than cure, but let's
Yeah,
say it
in case
falls.
by God forbid it falls off, we have people have described many things. Triple antibiotic irrigation and soaking it for 15 minutes in saline, triple wash, so on and so forth. But nothing can give a whole and soul protection to the graft. I would discard it, personally
Yeah.
speaking.
So I have some experience with this, Sunny. There are two times in my practice I have dropped the graft, and both the times I have reused it. What he said is, so first I soak it in normal saline for about 15 to 20 minutes, then a triple antibiotic wash again. We use the gentamicin, the vancomycin, and maybe kind of a ceftriaxone wrap, and then I have reused it twice. Touch wood, those patients haven't got infected, and they are doing so well. But the problem is, to go to another graft, you have to take a consent again. You have to go out, dewash, talk to the relatives. But then, of course, what Chirag saying is absolutely justified. It's not right on our part to use that. And of course, the infection, if it happens, then it's a very guilty situation. So, but I have had some experience to your question. So we welcome
Parag sir,
Dr. Ranjit.
Parag sir,
Uh,
before we wind up, one question from my side to
sure,
you. Uh,
sure.
since since our center is a very Sancheti Center is a very high volume center, and anything can happen over the graft harvest and graft repression and things like that. Do you? I have seen some surgeons take concern for two grafts in today's state, hamstring and peroneus, in case
Yes,
the graft gets amputated, which can happen in younger surgeons' hand,
yes.
especially in this forum. It's probably a message from your side to the younger surgeons. In case the graft gets amputated, SEMITI, what is the kind of backup? You come out, speak to the patient party and harvest another graft, or use the same graft with a suboptimal diameter, or
Yeah. So
keep a
if
graft in operation. Yes, sir.
again, I have a lot of experience with this when the in the initial stages of my practice, or even sometimes later, that the graft gets amputated. You changed your tendon stripper. Suddenly, you get a sharp one sometimes, and the sister's not informing you. You're used to your regular tendon stripper, and then the graft gets amputated, or sometimes there is fibrosis, and the graft is getting. So what I do is, if possible, I'll try to retrieve it. I will spend about 10 to 15 minutes. What the idea I have is I put the scope inside and then put the grabber by the side of the scope. So in case I can see the tip where I have lost the graft, then where it is amputated prematurely, I will try to retrieve it and do it. If not, then of course we have to consent the patient for either the peroneus longus same side or the quadriceps soft tissue. Again, I think it's a good graft. You can get good length with the quadriceps central strip. So I would fall back to one of those two grafts after asking the anesthetist or somebody to go and inform the patient. So that is the way I would bail out of this situation. Any differences? Any other questions? So we have Dr. Ranjit, sir. Ranjit, sir, can you unmute yourself so that we can have a few words from you? You'll have to. So welcome, Dr. Ranjit, the president of Arthroscopy Society of NorthEast. Can you please say a few words? We are very happy that you have launched this society, and you are the newest society under the banner of the arthroscopy. So please tell us about the society and a few words of advice from you.
Yeah. So thank you. It has been a long struggle to start, when you start something new in your place and without any support from anywhere else. So you need to learn yourself and do the mistakes and keep on learning in that way. So we started in that way. This is number one. Number two, I'm very happy that our small, tiny association has grown up with so many youngsters having exposed themselves to different types of arthroscopic advancement. I'm very happy about my youngsters, Mahibul, and those other guys who are across the Northeast. They are doing they're very sincere. Seem to be very sincere to learn the art of the things. So I'm happy that most of the patients which leave Northeast to different parts of the country will slowly shrink down so that our youngsters can take up and develop confidence in our patients. Number two, I'm very sorry that I had to join late because there was something came up. In between, I had to leave. So I was just like a shuttling between this and that. But then, so nice that you people are telling everything so nicely. Thank you very much.
Thank you. Thank you, Ranjit. And before we close, may I request the secretary of ASNE, Arthroscopy Society Northeast, to say a few words, Dr. Bikash.
First of all, I would like to thank Parag sir, Ashok sir, and all the um, uh, panelists present here for encouraging us, and also Rajiv Raman sir for encouraging us, for uh, uh, bringing us on board for this and for this Ortho TV live program. This is a really great opportunity for us. So that like ours is a very new association, was formed around 8-9 years back, but was dormant for a few years because of COVID and all. We have now revived it, and we hope to continue this. Rajiv sir has also formed, like in the last meeting, we had a discussion with Rajiv Raman sir about 2 or 3 fellowships from Northeast at Search Center. This sort of thing will definitely encourage the young people of Northeast to come forward, and I'd like to thank you all for this opportunity.
Yeah.
Thank you.
So thank you, Dr. Bikash. With this, we will conclude today's webinar through Arthroscopy Insights. I would like to thank all the speakers, Dr. Bikash, Dr. Kashif, Dr. Thejaswi, who unfortunately had some technical glitch, Dr. Mahibul, and also the president of ASNE, Dr. Ranjit, for tuning in. And of course, we had 2 very experienced panelists, Dr. Chirag from Bangalore and Dr. Sunny from Pune. Thank you for helping us to, get your experience to the large audience. I would feel in my duty if I do not thank OrthoTV for helping us to put this together. And I really feel that a platform, virtual platform created by OrthoTV through Ashok Sham and Neeraj Bijlani is going a long way for this education and dispersing knowledge. So thank you, Ortho TV. And with this, we will conclude today's webinar. One quick announcement is regarding very soon we are starting a surgical skills center for arthroscopy at Sancheti Hospital. And the next month, on the 6th of August, we have the inauguration of the Surgical Skills Center. So if there are any students who want to have the basic skills in arthroscopy, you can get in touch with Dr. Sunny or Dr. Kailash from Sancheti Hospital, and we would be very happy to take some members of ASNE for this basic surgical skills course. So with that, thank you very much and have a good evening ahead. Thank you. Bye-bye.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you so
all.
much.
Thank you, sir.
Okay, I think we are. Thank you, Ranjit sir. बंद करूं?
Bye. तो इसमें तो है